Shall we start?
Yeah, we can start. Sir, shall we start, sir?
Yeah, no problem. 9 o'clock, you can start.
Good evening, everybody. Under the IAP CCB Presidential Action Plan 2026, we are very happy to present session 3 of RUPE, Recent Updates in Pediatric Education, with none other than legendary teacher SBS sir as the convener. The last two sessions were standouts in their own way. Everybody still remembers the scintillating rendezvous between the SBS sir and Dr. Ramanan from UK in the session on HLH. The last session was on constipation and abdominal pain. On the surface, a seemingly simple topic, but with complex connotations. Today, we are here with session 3, Superbugs in Focus. So superbugs are not just futuristic, they are here. We are in the pandemic of antimicrobial resistance, where we have moved from treating infections to managing resistance. So today, to introduce our mentor, may I request Sudhakar sir to do the honors. This will be followed by a few words from SBS sir, and the mentor, Dr. Vidya, will take over the proceedings from there. Thank you.
Good evening to all of you. I'm very happy to invite Dr. Vidya Krishnan from Apollo, Infectious Disease Pediatric ID Consultant. Thank you, Dr. Vidya Krishna, for accepting to be a mentor for this RUPE program. Really, it's very, very important. Most of us, we simply write antibiotics without knowing the resistance pattern. And in future, especially the genetics, we may have to choose the antibiotic based on the individuals also, based on that. So many things are there. I'm not going to talk anything about it. And it's up to now it's for you to take over. I request Dr. SPSR to say a few words about the superbugs.
Thank you, Dr. Sudhakar. I have nothing to say except that super bugs are going to be the real microbes which are going to bug us in future. They are already bugging us a lot. I'm afraid treating super bugs is going to be more difficult than ever before in the near future. With Dr. Vidya Krishna around and with some very young brains trying to sort out the issues, I'm sure it will be a great learning experience. Thank you very much.
Thank you, sir. Thank you.
Over to our mentor, Dr. Vidya. The stage
Hello,
is
good
all
evening.
yours.
Yeah, thank you, Dr. Lakshmi. Thank you, SBS sir and Sudhakar sir. So today we're going to be talking about superbugs in a very practical way. But obviously, when we think of antimicrobial resistance and superbugs, what we have in our pipeline right now, the antibiotics are not going to be ever the answer. I think, as Dr. Sudhakar was saying, it's going to be something much more like at a genomic level, or we are going to be looking at phage therapy and many other things, maybe even immunization, vaccines against bugs, and so many things. We are not going to be so far-fetched in our discussion today. We thought we would sort of limit ourselves to 4 main superbugs that all of us see in clinical practice. When I started doing ID, say about 10 years ago, we didn't know to use many of the antibiotics. I had to go into ID to learn a lot of antibiotics, how to use meropenem, where to use meropenem, where to use colistin and all that. But that is not the scenario right now. For postgraduates who are studying right now, you are already dealing with superbugs in your pediatric ICUs and your NICUs, maybe to some extent in your wards, you already have ESBLs. So you should be empowered to identify and manage some of these infections. Not everywhere you're going to be having somebody to help you out. Your microbiologist should be kind enough. And maybe this will also be a, say for some, it will generate some enthusiasm for some of you to take up ID as a subspecialty as well. So without further ado, I'm going to first, the way we intend to go about this program is we are going to talk about first methicillin resistant Staph aureus, and then we'll move on to the resistant gram negatives. We'll have one talk on ESBL producers, and then we will have something on carbapenem resistant Enterobacteriaceae, and then the last talk will be on carbapenem resistant Acinetobacter. So for the first talk, I'm going to invite Dr. Shanmugapriya. So she is a pediatric PG from Sri Ramchandra Medical College Hospital, Chennai, and she's going to take us through methicillin resistant Staph aureus. Welcome, Dr. Shanmugapriya.
Good evening, ma'am. Thank you.
Yeah. Yes, your screen is visible.
Thank you, ma'am. Good evening, respected faculties and colleagues. Today, I'll be presenting on MRSA in children, which is a leading superbug challenge we face in pediatric practice. So to begin with a case scenario, this was a 5-year-old female child admitted with drug-resistant epilepsy and cortical malformation. Child was admitted post-op craniotomy and lesionectomy. Child had both EVD and central line in situ. Child had fever from post-op day 1. Initially, we considered it as a post-op fever, but on day 5 also, child continued to have persistent fever spikes and tachycardia. Suspecting sepsis, blood cultures were drawn from both peripheral and central lines, and child was started on IV meropenem and vancomycin according to our institute protocol. And we received a Bacter alert showing gram-positive cocci from the central venous catheter. Hence, central line was removed, and the final blood culture is as shown. The organism isolated was Staph aureus, and it was resistant to ampicillin, cefotaxime, and cloxacillin, which is the MRSA organism. Hence, final blood culture revealed MRSA. So, meropenem was stopped and vancomycin was continued. An infectious disease opinion was obtained, and echo was done to rule out vegetations, and the child responded well. So what is MRSA? MRSA is a gram-positive bacterium that is resistant to almost all beta-lactam antibiotics, penicillins like methicillin, oxacillin, and all cephalosporins except the 5th generation cephalosporins, which is the ceftaroline. The resistance mechanism is due to the presence of MEC-A gene on the staphylococcal cassette chromosome MEC, which is the SCC MEC. The MEC-A gene codes to penicillin binding protein 2A, which has low affinity for the beta-lactams, hence the resistance. So the clinical spectrum of MRSA in children varies from simple soft tissue infections to severe invasive diseases like bacteremia, necrotizing pneumonia, endocarditis, etc. So according to the study by Aldi et al. In 2024, a global meta-analysis, there was 5% prevalence of colonization of MRSA in healthy children, which had highest prevalence in Asia. And a study by Oliven et al. In 2024 showed 15 to 20% of Staph aureus infection belong to MRSA. And there has been rising prevalence and high morbidity and economic burden since 1990s. Children serve as a key reservoir for community and healthcare spread of MRSA. So our ICMR annual report of 2024 showed MRSA steadily increased over the past 8 years of surveillance, which was 33% in 2017, and it was nearly 53% in 2024. So coming to community-associated and hospital-associated MRSA, though there is a difference, the lines have blurred these days due to the coexisting features. So first, community-associated MRSA occurs in previously healthy children, and common infections noted are skin and soft tissue infections and invasive diseases like necrotizing pneumonia. The genetics difference between community-associated and hospital-associated is the SCC MEC, which cephalococcal cassette chromosome MEC4, while it is SCC MEC2 or 3 in hospital-associated MRSA. So antibiotic susceptibility, the community-associated MRSA are more susceptible to non-beta-lactams like clindamycin, cotrimoxazole, etc. So now it's community-associated is dominant in many pediatric settings, and it's rising in community. While hospital-acquired MRSA occurs in children with comorbidities, recent hospitalization, and the use of prior antibiotics, they are more invasive and nosocomial, causing bacteremia, device-related bacteremia, pneumonia, and surgical site infections. They are highly multi-drug resistant. They are often resistant to clindamycin, fluoroquinolones. While the healthcare exposure, admissions, catheterizations, antibiotics, and prior 3 months are the risk factors. Still, major proportion of MRSA is in hospitals, but proportion is declining relative to community-acquired strains. So the drugs that act against MRSA, first will vancomycin, which is the gold standard. It's the first line for serious or invasive infections. The dose is 15 mg per kg per dose, IVQ 6th hourly. While trough target monitoring is important, where maintaining a trough target of 15 to 20 microgram per ml in severe cases and 10 to 15 microgram per ml in mild cases is important. Next drug will be clindamycin, which can be given as both IV and oral. It's excellent for the community-acquired MRSA skin infections, and the dose is 10 to 13 mg per kg per dose every 6 to 8 hourly. D-test is important to find the inducible resistance before starting clindamycin. So teicoplanin is less nephrotoxic than vancomycin, but it has poor CNS penetration when compared to vancomycin. The loading dose is 10 mg per kg IV every 12th hourly for 3 to 5 doses. Then a maintenance of 10 mg per kg once daily is enough, as it has a longer half-life. And then linezolid, which can be an alternative to pneumonia when vancomycin is not feasible. So in younger children, the dose is 10 mg per kg every 8th hourly, and in older children more than 12 years, it's 600 mg BD. And daptomycin has been recently evolving as an emerging salvage option for complicated infection with a dose of 6 to 10 mg per kg per day, while it has limited pediatric data. And cotrimoxazole, which is the trimethoprim sulfamethoxazole, is a good oral option for the community-acquired MRSAs. So source control is essential. Drainage and debridement alongside the antibiotic therapy must be done. So local susceptibility pattern also matters because clindamycin resistant varies geographically. So drugs to be avoided or used with caution. So all beta-lactams are inherently ineffective by definition due to their MEK mediated resistance, except for the 5th generation cephalosporin ceftaroline. And tetracycline is usually avoided in children less than 8 years and a long course of more than 21 days because it has side effects like bone growth defects and tooth enamel discoloration. So it's acceptable in older children with community-associated skin and soft tissue infections. Rifampin is never used as a monotherapy because of their rapid resistance, and it's used only as an adjunct in selective cases. So fluoroquinolones is not the first line drugs in MRSA because of the resistance and variable activity. So treatment of MRSA infection, this is according to the IDSA guidelines. The first line agent is vancomycin. Vancomycin remains the mainstay for serious or invasive MRSA infection in children. The key principles are clindamycin can be used if the local resistance is low, that is less than 10%. Linezolid is a common alternative to vanco in stable patients. Daptomycin is emerging with limited pediatric data, and tetracycline is usually avoided in younger children. Duration of the treatment is individualized based on the clinical response and source control. So first, the skin and soft tissue infection can be from minor to complicated. In case of minor infections like impetigo, secondary eczema or ulcers, we can use topical mupirocin 2% ointment. In case of outpatient abscess, first the source control, which is the incision drainage, is primary, and the empirical coverage with clindamycin and cotrimoxazole or linezolid in case of severe or extensive diseases can be used. Hospitalized skin and soft tissue infection, vancomycin IV can be used. If the child is stable and there is low vancomycin, low clindamycin resistance, clindamycin can also be used at a dose of 10 to 13 mg per kg. And an alternative to vanco and clindamycin is linezolid. So duration is 5 to 10 days of outpatient treatment, and if the child is hospitalized, can be up to 7 to 14 days. Hygiene, decolonization with nasal mupirocin and chlorhexidine washes are important to prevent recurrence. So in case of bacteremia and infective dose, vancomycin is the first line. Duration of treatment is 2 to 6 weeks, and the duration depends on the source and the metastatic foci. Alternative to vancomycin is daptomycin, which is given as an IV once daily dose. Clindamycin or linezolid is usually not recommended as in case of intravascular source because it's a bacteriostatic drugs which doesn't respond well to the bacteremia. Routine rifampin and gentamicin addition is not recommended these days, and echocardiogram is done when recommended for congenital heart disease or the child had bacteremia persisting for more than 2 to 3 days, as MRSA has more prevalence to seeding in the heart, causing an infective endocarditis. And the next is a case of pneumonia. Again, IV vancomycin is the first line, followed by, if clindamycin resistance is low, we can give clindamycin, and an alternative to it is linezolid. So duration is about 7 to 21 days, depending on the extent. In case of empyema, drainage is must, and teicoplanin can be used, but it has a lower lung penetration than vancomycin. Hence, vancomycin remains the first line of drug. So in case of bone and joint infection, vancomycin, clindamycin, or daptomycin can be used. Surgical debridement is essential. So in case of osteomyelitis, 4 to 6 weeks of treatment, and septic arthritis requires 3 to 4 weeks of treatment. CNS infections, again, vancomycin has the better penetration than teicoplanin. If there is a shunt infection, shunt removal is required until the CSF cultures turn negative. In case of neonatal MRSA, mild pustulosis can be treated with topical mupirocin. In case of extensive diseases, IV vanco or clindamycin can be used until bacteremia is excluded. So in case of neonatal, confirmed neonatal sepsis, IV and vancomycin is recommended as per the Red Book dosing. Vancomycin monitoring is done by the monitoring of trough target with 15 to 20 microgram per ml for severe infections like bacteremia, endocarditis, necrotizing fasciitis. And AUC MIC target of 400 to 600 must be maintained for efficacy. Source control is important and critical wherever feasible. Empirical therapy is guided by the local susceptibility patterns. Many pediatric data are limited, hence therapy should be individualized. Infectious disease consultation is recommended whenever possible.
10 minutes up, Shanmugapriya. So please, yeah.
So persistent MRSA bacteremia, historical definition was more than 7 days of positive blood culture while on appropriate antibiotics. But the current definition is more than 1 calendar day after initiation of appropriate antibiotic therapy. Still, if the follow-up blood culture is positive, then it's called as a persistent MRSA bacteremia. So the strategies used are ceftaroline can be added either to vancomycin or daptomycin. Daptomycin monotherapy is has a risk of resistance, hence it's often paired with second agents like cotrimoxazole. So setting the clock, when on initial diagnosis, we can initiate monotherapy with vancomycin dosed by the AUC MIC or daptomycin. A follow-up blood culture must be drawn within 24 to 48 hours. When a single blood culture positive occurs after 24 hours of treatment, it is considered as a persistent MRSA bacteremia. Hence, echo should be done to rule out endocarditis. When in case of persistent bacteremia, simply switching from vancomycin to daptomycin is not recommended because of the high risk of cross resistance. So, hence, ceftaroline can be added, which binds to the PB protein, penicillin binding protein 2A, or a high dose daptomycin with a synergistic agent like cotrimoxazole can be added. So this is a Sabato trial performed in 2024, which evaluated whether we can safely switch from IV therapy to oral therapy in earlier. So the trial included a control arm which received 14 days of continuous IV therapy, and the intervention group which received 5 to 7 days of initial IV therapy and then stepped down to oral therapy. So the key findings which were noted were there was no much treatment difference between both the IV group and the oral switch group, and only 0.7% treatment difference was present. Hence, it was non-inferior to the standard IV therapy. But the Sabato trial is limited only to the adult cohorts, and its findings cannot be generalized to children due to the lack of pediatric specific clinical trials. So take-home points: MECA gene renders MRSA resistant to nearly all beta-lactams except ceftaroline. Vancomycin remains the gold standard for the serious invasive infections. Vancomycin monitoring is important, maintaining a trough target of 15 to 20 microgram per ml or an AUC-MIC target of 400 to 600 to ensure efficacy. Teicoplanin has lower lung and CNS penetration than vancomycin. Essential source control is important. Aggressive control via drainage, debridement, or device removal plays an important role. So managing persistent bacteremia, Bacteremia lasting for more than 1 day is complicated. Hence, it requires an intensive workup and an echo. And step-up combination with ceftaroline and vancomycin is important rather than a simple monotherapy switch. Thank you.
Thank you, Shanmugapriya. That was sort of very comprehensive review of MRSA. Sort of many things have not changed in the sense maybe clinically we are slightly more confident with using teicoplanin. Earlier we used to be restricting teicoplanin to outpatient therapy, but more and more we are trying to use teicoplanin even in inpatient practice. But having said that, I mean, still the data, head-on-head data of vancomycin versus teicoplanin in serious invasive infections is limited. So when you have a persistent bacteremia, or if you have a bacteremic MRSA, still probably vancomycin has more data than teicoplanin. And one other thing that I thought we should mention here is you were talking about the combination of ceftaroline and daptomycin, isn't it? So ceftaroline is available in India. Unfortunately, it is not licensed for children in the pediatric age group in India. But then if available, in that scenario of where you have a persistent bacteremia not responding to vancomycin despite trough levels and source control and all those things, there's something called as a seesaw effect. So when the resistance to MRSA starts increasing, actually the beta-lactam sensitivity starts returning in a way. So that's why sometimes beta-lactams are combined with glycopeptides or with daptomycin to try and optimize that the treatment. So with that, I think we'll take audience questions in the end, or maybe even from SBS sir at the end. Sir, you want to say something, or shall I move on to the next person? SBS sir.
Two or three comments. One,
Yes.
Brilliant presentation, except one point was missing, because it's a fundamental point which most ID people will know, but general pediatricians may not know. Once you mention, for a bacteremia which is not responding within 48 hours, the tendency is to start daptomycin, but you should not do that if it is pneumonia. Daptomycin should never be used for pneumonia. That's something it inactivates surfactant, so it should not be used. So even if it is pneumonia, bacteremia, if it is resistant, do not add daptomycin, it won't work. That is one. Second, even if it is a bacteremic illness, vancomycin alone will not be enough in toxin-producing diseases like toxic shock syndrome or severe forms of, staphylococcal skin scalded syndrome. In my experience, whatever SSS I have seen, it responds very well to any antibiotic you give till the babies get better in 48 hours. I've never seen a staphylococcal skin scalded syndrome child going in for shock and things like that. It's extremely rare, extremely rare. So if you want to use only one drug, even clindamycin should be good enough, because staphylococcal skin scalded syndrome is very, very rarely only associated with bacteremia or septic shock. That is one. Second, if you have toxic shock syndrome, upfront you have to use a combination of vancomycin plus linezolid or vancomycin plus clindamycin for toxin neutralization and toxin production decrease. Okay. And finally, I don't know, for MRSA, there are several new drugs which are coming into the market. Of course, I don't know, the Divya might add, I don't know if, books mention tedizolid as an alternative to linezolid with lesser risks of bone marrow suppression, lesser risks of the irreversible neuropathy, and of course, dalbavancin and oritavancin are two drugs mentioned in literature, and they are also talking about very good drugs. I don't remember the names. I think one of them is, Divya might know, Vidya might know. I think it is epidermicin, a new drug which is being tried for MRSA. These are the things which I read somewhere recently on MRSA. These are
Yes,
and
sir.
last is if you have bacteremia, you should not be using either tetracycline, that is doxycycline or cotrimoxazole. They don't eradicate bacteremia. You should use them only when there is no bacteremia, or you should use them as add-on drugs to something which is more effective, like your daptomycin or vancomycin. So cotrimoxazole, doxycycline should not be used. And I want to ask Divya, what about use of tigecycline for MRSA? If it is there is no bacteremia, is there an alternative drug if the child is critically ill, no bacteremia, severe? I thought there is no mention in the literature about use of tigecycline in intra-abdominal Staph aureus infection. And last thing I wanted to add was that if a child is very, very stable hemodynamically, not toxic, even if you suspect MRSA infection, upfront starting vancomycin is probably not required. You can get away with clindamycin in most cases. These are my comments. Over to
Yes, sir.
Vidya.
Yes, sir. So, thank you, sir, for those comments. So, first of all, for all the postgraduates who are watching, so when you are talking about a Staph aureus syndrome, as sir said, you need to know when you're using your drugs, what you're targeting. Are you targeting a bacteremia or an endovascular infection, or are you targeting a tissue infection or CNS infection? So, because the drugs that you use, the penetration, we call it as PTA, percentage of target attainment at the site. So that is very, very important. For example, if you're talking about a pneumonia, you want a drug like linezolid, which really goes well into the lungs. Or if you're talking about a bone and joint infection, linezolid, maybe clindamycin, those are very good drugs. So that is very important. Whereas when talking about bacteremia, these drugs are useless. As we were talking, we have to use drugs like vancomycin, or if vancomycin fails, then something like daptomycin combination and other things. About the newer drugs, tedizolid, dalbavancin, and all that. Yeah, I think again the approval in India is a little tricky. But then, having said that, I have used dalbavancin. Tedizolid is a little bit of a problem, though the literature seems to say that the adverse effects are lower. In fact, most of my adult colleagues who practice, they tell me that even when they use tedizolid for a longer time, then still the side effects are the same. The cytopenia is the same. Neuropathy, I'm not very sure, but it doesn't seem to have a great advantage in clinical practice over linezolid. But obviously, these are newer drugs, so we have to wait for some more time before we get more data on them. And dalbavancin is a very useful drug. Again, not approved in children, but it's just once a week and all that. So a patient can not even be in the hospital. Even for an endocarditis, he can stay at home, come to the hospital once a week and take the medicine and go home. So those are interesting developments, but pediatric data is few, and so we have to wait for that. And about the last point, tigecycline, fosfomycin, these are two drugs which have very good MRSA activity, but unfortunately, they are very broad spectrum. So unless you have a polymicrobial scenario where you also need to treat a CR E. coli with an MRSA, I wouldn't prefer to use tigecycline and fosfomycin. We have better drugs for MRSA. We'll spare TG and phospho and all that for situations which are very extreme.
Another drug which is mentioned in literature, which is not available in India, but what is that? Quinoprestin, and what is that called?
Quinoprestin and dalfoprestin. These have been in the literature for quite some time.
Yeah.
Yeah.
It is used very much in the West for bone
Yes.
joint MRSA.
I think MRSA is, having said, is a predominantly a West pathogen, which is very common in the West. We hardly see. That's why many times even our EMPRIC cover doesn't include MRSA in many situations. So yeah. So I think in the interest of time, shall we go ahead, sir, for the second
Please go
Thank
ahead.
you, Shanmugapriya. Very well done. And the second talk will be on ESBL gram negatives. For this, we have Dr. Kavita. Dr. Kavita is a pediatric postgraduate from Rainbow Children's Hospital in Chennai. Kavita, you can start sharing your screen, please. Kavita, are you there? Yeah.
Yes, ma'am.
Yeah, please.
Good evening, everyone. Myself, Kavita. I'm here to present on ESBL E. coli and shortly on AMC. So ESBL, it stands for extended spectrum beta lactamases. These enzymes, they are usually secreted by the gram-negative bacteria, most commonly E. coli and Klebsiella. And they inactivate most of the penicillins, third and fourth generation cephalosporins, and also aztreonam. But they do not inactivate cephamycins or carbapinums. And these can be neutralized by beta-lactamase inhibitors like clavulanic acid, tazobactam, or sulbactam. So clinically, when a patient is not responding to cephalosporins, ESBL has to be suspected. So this is the classification. ESBL, it belongs to Ambler classification A and D and group 2 of Bush-Jacobi classification. And in Ambler classification, we have SHV and TEM, which are the earlier first detected genes for ESBL. And CTXM has now become the most common detected gene locally, globally. The resistant mechanisms. ESBL, it breaks the beta-lactam ring of cephalosporins and makes it inactive. And resistance is achieved via horizontal gene transfer also. So the bacterial integron, it acts as the plasmid. Coming to the epidemiology, ESBL infections are increasing worldwide, especially in developing countries like India, due to inappropriate antibiotic usage, ICU stay, or in immunocompromised states. Among ESBLs, E. coli are the most common organisms producing ESBL. And study shows that almost 60 to 80% of ESBL and E. coli isolates may produce ESBL enzymes. So this is the graph which shows the trend of antibiotic susceptibility over time. So we see there's a gradual decline in the susceptibility to third generation cephalosporins over time. At the same time, there is a susceptibility to carbapinums is relatively preserved. So this reflects the prevalence of ESBL organisms, both to E. coli and to Klebsiella pneumoniae. So these are the genes which are present in E. coli and Klebsiella pneumonia. So most commonly, these genes are most prevalent in the Klebsiella group than in the E. coli. And TEM is the most commonly seen in the Klebsiella pneumonia group. Coming to the diagnostic tools for detection of ESBL, this is the primary step where Kirboyer desk and Vitek is used, and this detects the third generation cephalosporins, and this is the zone of inhibition seen, and we should suspect if ESBL if this is seen. So, but we should confirm it by phenotypic confirmation using double disc synergy test, where we add clavulanic acid and the zone of inhibition it increases, and the ESBL is thus confirmed. So these are drugs used for ESBL infections, namely carbapinums and beta-lactamase inhibitors, and usually cefepime, ceftazidime, avibactam, and fosfomycin and tigecycline are usually avoided in ESBL infections. Coming to the IDSA guidelines, for uncomplicated cystitis caused by ESBL E. coli, nitrofurantoin and sulfamethoxazole is the preferred drug given by the guidelines. Nitrofurantoin and cotrimoxazole is the preferred drug given by the guidelines. And we should avoid amoxiclav and doxycycline in case of uncomplicated cystitis. So in pyelonephritis and complicated UTI, carbapinums should be initiated upfront and has to be downgraded once the patient's symptoms improve to cotrimoxazole or ciprofloxacin or levofloxacin. And fosfomycin and nitrofurantoin doxycycline have to be avoided due to poor renal penetration. So the role of piperazole and tazobactam comes, the piperazole and tazobactam MIC testing may be inaccurate or poorly reproducible when ESBL enzymes are present or in the presence of other beta-lactamase enzymes like OXA1. So the effectiveness of tazobactam may be diminished for organisms with increased expression of ESBL enzymes or by the presence of other beta-lactamases like AMC enzymes. So when there is an infection outside the urinary tract, we start with meropenem or imipenem cilastatin combination in patients with hypoalbuminemia, or in case of OPD treatment, we start with ertapenem and we downgrade to when there is hemodynamic stability and the patient improves. So if piperacillin tazobactam is started as an empirical therapy for uncomplicated cystitis and later ESBL is detected, so we should not change the therapy unless the patient is deteriorated. So this is a study done which showed almost equal clinical success when treated with piperacillin tazobactam and ertapenem in case of children with pyelonephritis caused by ESBL E. coli. And the mortality was higher in case of piperacillin tazobactam arm in children with bloodstream infections from a urinary source. So the European Society for Clinical Microbiology and Infectious Disease Guidelines for ESBL E. coli, it tells about use of carbapenems in case of bloodstream infections and also severe infections. And ertapenem is used as a targeted therapy in case of bloodstream infections without septic shock. Or in case of low risk or non-severe infections, or to downgrade the therapy, piperacillin tazobactam or amoxiclav or quinolones can be considered. And we should also consider cotrimoxazole in case of non-severe complicated UTI. An in vitro study also showed that aminoglycosides preference in children with complicated UTI without septic shock for a shorter duration of therapy. So meropenem, this is a carbapenem which binds to the penicillin binding proteins and inhibits the peptidoglycan cross-linking and weakens the cell wall and causes cell lysis. And they're highly resistant to beta-lactamases, so usually preferred in ESB. Coming to pharmacokinetics, they're usually absorbed via intravenous route and their excretion is mainly via renal, so drug doses has to be changed in renal compromised patients. And it has good tissue penetration and also it can cross the blood-brain barrier. The pharmacodynamics, it is a time-dependent killing. So if meropenem, any carbapenem is given, it should not be infused over 30 minutes like a bolus. So it has to be infused over 2 to 3 hour extension so it can reach above the MIC and the effect of drug increases. It also has post-antibiotic effect and also has bactericidal action. It is used in severe and resistant infections like meningitis, sepsis, hospital-acquired pneumonia, complicated intra-abdominal infections, complicated UTI, complicated skin and soft tissue infections, and the most common adverse drug reaction seen is seizures, but is less compared to imipenem. So this is a Merino trial which compared the effectiveness of piperacillin tazobactam versus meropenem on a 30-day mortality. The population included were the hospitalized adults with at least one positive blood culture with E. coli or Klebsiella. The intervention was piperacillin tazobactam 4.5 gram given intravenously over 6 hours. And the control group was meropenem, which was receiving it over 8 hours. And the outcome expected was all-cause mortality at 30 days after randomization. There were about 2.7% non-serious, safe, non-fatal serious adverse event in PIPTAS group and 1.6% in meropenem group. The primary outcome, it showed about 12.3% mortality in PIPTAS group and 3.7% in meropenem group. But these findings do not support the use of piperacillin tazobactam as carbapenem sparing therapy when compared with meropenem for patients with ceftriaxone-resistant E. coli or Klebsiella pneumonia infections. As the study groups were not well balanced, since there were more UTI patients in the meropenem group when compared to more intra-abdominal infections, surgical site infections, pneumonia, and catheter-associated infections, neutropenia patients in the piperacillin tazobactam. And the mortality was very low in the meropenem arm which was predicted based on the previous study. And the variables which were known to worsen the outcomes were associated with the opposite effect, as meropenem was given over a longer duration of therapy and piptaz was given for a shorter duration. And the influence of the study group is also too diminished, as empirical antibiotics was given for 3 days and the study drug were started and they were given only for a duration of 7 days. And in piptaz group, they missed the effect of AMC and OXO1 gene. So a brief note on AMC. This is enzyme produced by gram-negative bacilli, and they are resistant to beta-lactamase inhibitors. And this belongs to class C of amylar classification. And this can be induced, which is a differentiating feature from ESBL. This is most commonly found in Enterobacter, Citrobacter, and Serratia. And beta-lactam, beta-lactamase inhibitors versus carbapenem in pilot RCT showed more microbiological failure towards BLBL lice. So in Enterobacter cloacae, Klebsiella aerogenes, and Citrobacter fluendae, we should avoid using third generation cephalosporins upfront and consider carbapenems like high-dose cefepime if the MIC is less than 2. And in case of Serratia, Moroccanella, and Providentia, and the treatment has to be guided according to antibiotic susceptibility testing. We should also prefer cefepime in case of high inoculum infections. So to compare ESBL and AMC, ESBL is inhibitable by clavulanic acid and AMC is not. And they are sensitive to cefamycins like cefotetan and cefoxitin, and AMC is resistant to cefamycins. And ESBL is not inducible, and AMC is inducible even after starting treatment. So take-home message for today: if ESBL is suspected, we should always confirm it with clavulanic acid synergy. And carbapenems are the drug of choice for severe infections, and we should de-escalate therapy whenever the patient improves. Thank you.
Yeah, thank you, Kavita, for taking all the efforts to do such an exhaustive review. So to summarize, just a few points that I want to reiterate to the postgraduates who are listening to us today. So when we talk about ESBL, so the two major drugs that we have in our hand is carbapenem, which is essentially meropenem. And the other hand, you have your BLBLIs called as piperacillin tazobactam or cefoperazone sulbactam. So in clinical practice, we have traditionally been using the beta-lactam, beta-lactamase inhibitors in our less severely ill patients, typically patients in the ward or in the outpatient if we have to use an intravenous antibiotic, or the patients who have less severe infections like say an UTI or a biliary infection like cholangitis. Whereas we have typically reserved meropenem for our ICU severe patients or neutropenic patients or where the inoculum of infection is very high. The reason being, we do not want to use meropenem for everybody because once you start using it, then carbapenem resistance will go up, which we will be seeing in the subsequent two speakers. So this Merino trial was was designed to see if what we were doing was right, whereas piptaz was as good as, it was non-inferior. It was not as good as, it was non-inferior to meropenem. Unfortunately, for various flaws that were associated with that trial, they actually landed up saying that piptaz was not non-inferior and that we should not be using piptaz for any of the ESBL infections at all, which is what the US guideline or the IDSA guideline, it is not even a guideline, it's more like an expert opinion. So that guidance has taken it as a reason for saying that we should not be using beta-lactam, beta-lactamase inhibitors at all for ESBL organisms. Whereas the European guidelines, the Indian ICMR guidelines, we are more still in favor of using beta-lactam, beta-lactamase inhibitors, as I was saying, for less severe infections or for your ward patients and other settings. So as of now, the verdict is not out, but we would continue to use beta-lactam, beta-lactamase inhibitors as carbapenem sparers. The main thing for you all to concentrate on is the treatment of UTI. No? So it's just remember that nitrofurantoin, oral fosfomycin, these are useless for cystitis, whereas drugs like cotrimoxazole and fluoroquinolones, if they are sensitive, they are very good for pyelonephritis also. So you can treat a pyelonephritis with cotrimoxazole if they are stable and like the initial febrile phase and everything is settled. So these are important things for you from this talk. And in the interest of time, I think I will just ask sir, if you want to add anything, or should I just ask Kavin to?
Just two comments.
Yes, sir.
One, one drug which we use and our sensitivity is very good in our hospital data with ESBL is cephalosporin sulbactam, which is missing in the list of drugs for ESBL. It's an extremely good drug. Even if it is bacteremia, you can use cephalosporin sulbactam and you can get away if there is sensitivity. That is one. Second, if there is no bacteremia and the sensitivity is there to gentamicin or amikacin, you can treat these patients non-bacteremic ESBL UTIs with injectable aminoglycoside. They are not inferior to piperacillin tazobactam. The sensitivity is good. They are not dangerous. These are my only two comments.
The point well taken. The cephalosporin sulbactam is not mentioned in the Western guidelines, and ECMID guidelines actually says that it doesn't want to comment on cephalosporin sulbactam as there is no data, but perfectly agreed. In clinical practice, we use because we find it useful.
We don't use piperacillin tazobactam if there is sensitivity to cephalosporin sulbactam. We don't use meropenem either.
Yeah. Okay. So with that, we'll move on to the next talk. The next talk will be by Dr. Kevin Maharaj. He's from CMC, and I'm going to share his slides because he has some issues with sharing. And he has a very interesting talk on carbapenem resistant enterobacterials. So, Kevin, I'm just let me know if you're, yeah. Kevin, do you want to start?
Yes, ma'am. I'm not able to see the slides though.
Really? Is everybody else able to see?
Yeah, we are able to see this.
Yes, we are able to see.
Okay.
You.
Sure, ma'am. I'll just start the slide
Yeah.
presentation. So today I'll be talking about the carbapenem resistant enterobacterials. Before jumping into the topic, I just wanted to brush up mildly about the introduction part about the gram-negative bacilli and why is it notorious in our hospital settings and what are enterobacterias. It'll just take few couple of minutes. So gram-negative bacilli as such speaking, if you look at the structure of anatomy of a gram-negative bacilli, you can see there are three layers: inner membrane, periplasm, and then the outer membrane. So the two things which I want to focus today is on your periplasm and your outer membrane. So your periplasm is a place where you have all the enzymes, all your carbapenemase or your extended spectrum beta lactamase enzyme which are produced in your gram-negative bacilli. And then the next part is your outer membrane. Your outer membrane is a part where you can notice that all the porins are present. Though these porins are responsible for all the efflux on all the resistance that are going to happen in an gram-negative bacilli. And the other thing is that the last layer, that is your lipopolysaccharide saccharide which is present, which is responsible for all the toxic shock which is happening in a patient with gram-negative sepsis. So what are the enterobacterials in assets? So I'm going to mainly focus on Klebsiella and Escherichia coli predominantly now, because that is the other parts are beyond the scope of the current presentation. So coming to the definition. So what is the definition of carbapenemase resistance? So when there is a resistance of more than one equal to of carbapenem, that is a imipenem, meropenem, or ertapenem. If any one of this is resistant, it is defined as carbapenem resistant enterobacterials. So what are the mechanism through which that it can form a resistance? It could either be a carbapenemase that is producing or a non-carbapenemase mechanism. So why is it important to know? It is very much important, which you'll get to know in the upcoming slides. So what are the mechanisms of carbapenemase resistant is? So there are three arsenal carbapenemase producing enzymes. One is your Klebsiella pneumoniae carbapenemase, and then your metallo-beta lactamase, and then the last one is your OXA48 like enzyme. So the KPC and your OXA both are produced, and the both have the similar mechanism by which what will happen is your beta lactamase chain, which is present in your penicillin, has been hydrolyzed, and then it will cause resistance. The one fancy mechanism about your metallo beta lactamase is that from the name you can come to a conclusion that there is a metal required. So zinc is required. So zinc will cause like an hydrolyzing component where it will draw in the water, and further it will cause hydrolysis of your antibiotic. So why is it important to know about this? So the second part of it is a non-carbapenemase resistance. So in that, just like how I mentioned earlier, your outer membrane contains your porin. So these porins, where you can see that when there is a porin disruption, there is a part where the resistance is going to happen, and then a periplasmic membrane where all your carbapenemase and ESBLase is going to be produced. So your ESBL amplification and a porin disruption will eventually lead to a clinical carbapenemase resistant. So coming to the treatment. So so I just spoke about all these mechanisms. It is not for a theory basis, but for your clinical practice. How do you actually find out whether a child is actually having a carbapenemase or non-carbapenemase is by a test called as CARBA-NP test. I've not mentioned that in the slide, but I just wanted to briefly talk about it. So your CARBA-NP test is a test where it will help you know whether the child is having carbapenemase resistance or not. How does it function? So you take a blood culture of a patient, and then you found that the child has grown an ESBL. So, and then what is the next step you do is that you make sure that you take that blood culture, and then you introduce your carbapenemase, and then if the pH of the blood culture has changed, if it has an carbapenemase, it will definitely break the carbapenum. So what will happen to that? There'll be eventually a lysis of your carbapenum, and then the pH of your when there's a change in your pH, there'll be change in the color where we'll note that the child is having a resistant or not. So this will grossly tell you whether the child is having a carbapenemase and non-carbapenemase. To further to do is by genotyping, where you can know what exactly is that. So for your Klebsiella pneumoniae, where non-carbapenem is producing, there is a treatment of guideline of extended infusion of meropenem. But currently this practice is not much preferred. Whereas your KPC producing CRE, the preferred drug is your meropenem verbabactam and ceftazidime avibactam. But one thing about this is that in India, we don't much find meropenem and verbabactam, but predominantly ceftazidime avibactam is used. So, if there's one thing which I want to stress today about my presentation is that how do you defeat your metallo beta lactamase? So why am I stressing more on about your MBL is because that your MBL it's never alone. It is always associated with your ESBL. So the thing is that when you use a monotherapy like aztreonam, your aztreonam will go and break your MBL. It has no doubt about it. But the problem about aztreonam is that your aztreonam cannot withstand your ESBL, because your ESBL will start to produce a serine trap which will lyse your aztreonam. So what is a way through which you can overcome this MBL is by combining a therapy of avibactam and aztreonam. But this combination is not present in India. So the combination which is present in India is ceftazidime avibactam plus aztreonam, which will overcome this MBL. So you should always keep in your back of your mind. So when a child is having MBL, you should always know that it will always be associated or will be with ESBL. So just like how I mentioned earlier, so what is the treatment of MBL producing? So ceftazidime avibactam plus aztreonam. And I have mentioned the rationale behind it. And then coming to your OXA48 like producing enzymes. So these enzymes are not much of a burden in India because you don't find much in here, and it's usually predominantly found in the US. So, but still it's a weak enzyme. It is covered by ceftazidime and avibactam. And then coming to the next slide, where you can look at the graph in your y-axis and there is still x-axis. That's the same thing I want to stress again, is that in your y-axis, you can see that the ceftazidime avibactam, and then in your x-axis, you can see your metallo beta lactamase, where I have mentioned that it requires aztreonam. So that is the one thing which you have, that is the one take-home point which I want you guys to take home. And then coming to the burden in India. So the burden of ESBL, E. coli, and KPC is that you can look at the graph. The downfall of how the susceptibility of imipenem and meropenem is slowly falling down in both the graph. It looks very dangerous. So coming to the next slide, how is the ICU setting? What is the burden of enterobacterials in your ICU? So when you look at the panel 2, that is your ICU burden, you can look in India, there is carbapenem resistant producing organism 62%, but in contrast to USA, it's only 0.6% of E. coli. And then at the other part, when your Klebsiella species is produced at 76% of the time, it's usually resistant, whereas in USA, it's only 7.2%. So this is actually a very sad part to know about our ICU setting, because there was a trial which was done. It was an IMPRESS multicentric study trial which was done in India, which included 936 patients. So in that, it was noted that the first line empirical antibiotic that you give to a child it was only sensitive for 55.2%, effective within 24 hours. So what does that mean? The rest of the organism which was produced was not able to kill the bacteria with the antibiotic which we are giving to them. So it isn't because because it's very crucial for an ICU setup for a child who's coming in with an full-blown sepsis and with an full-blown sepsis and who's having a very resistant organism. We make sure that we hit him hard with an antibiotic. But after the study, it just looks like the whatever antibiotic we're giving, like 1 in 2 patients are not even getting the effective antibiotic, and obviously the mortality rate of a patient who's coming like this would be definitely increased. And then coming to the next study. So this was one study which was done to know what is good. Is it ceftazidime avibactam or polymyxin? So it was an straight away win that ceftazidime avibactam was way better, because it was noted that in this study that the mortality rate was reduced by mortality rate in the first 30 days was reduced in ceftazidime avibactam, and then there was higher clinical success with ceftazidime avibactam, and then the nephrotoxicity of ceftazidime avibactam is much lesser when compared to polymyxin. So this is one thing which just stood out in this trial, but I just want you to know that it is an open trial. So the data of this which is little dicey. So coming to polymyxin, which I mentioned, the points which I want you to know about polymyxin is that the polymyxin drug, it has a higher nephrotoxicity. So it is very, so the systemic involvement of giving polymyxin will definitely lead to kidney failure. But the other thing which I want you to know is that polymyxin should always be avoided in patients who are having renal injury. So this polymyxin has to be always used with caution. And coming to the other drug called fosfomycin. So this fosfomycin use is actually speaking, this fosfomycin use is always, it is never used as a monotherapy. It is always used as a synergistic adjuvant. So it is usually combined with ceftazidime avibactam or meropenem to achieve its full potential. And it can be used in all your UTIs, in your hospital-acquired pneumonia, skin tissue infection, and your bloodstream infection. And then the one thing it has a higher tolerance rate. And then the electrolyte disbalance are very mild, which can be even avoided in this setting. And then coming to the last one, the last antibiotic which I wanted to tell you is that it's your the last resort is your tigecycline. Your tigecycline is susceptible to most all of your MRSA, VRSA, ESBL, and all your Klebsiella pneumonia producing organism. But one gap is that it is not sensitive to the other enterobacteria such as Pseudomonas, Proteus, and Providencia. So what is one thing is that this tigecycline cannot be used in bloodstream infection because the bioavailability in your serum is very much low. So you should make sure you should always have, if a child is having bacteremia, that you have found that an bacteria has grown in a blood culture, tigecycline shouldn't be your first drug which should be popping in your mind. So this is the overall algorithm which I just made, which was made little concise so that you just have an idea. So you confirm that a child is having carbapenem resistant enterobacterial, say, and then like I told, the carbot test or your genetic test which can be done, and then it splits into all which type of resistance is present. So what is the reason to know that is because each resistant has its own. So for non-CP, it's your extended infusion of meropenem. For KPC, it's usually meropenem verbabactam or it's ceftazidime avibactam. For OXA48, it's usually a monotherapy. But for MBL, it is how I mentioned earlier, it was ceftazidime avibactam and aztreonam, which has to be given simultaneously in both hands when you're giving it. And then the take-home message which I want you to know is just like how I mentioned earlier, your IV fosfomycin has to be always used in synergy, and then your polymyxin use should always keep in your mind that it is a highly nephrotoxic drug. So you should always keep that as a second line when a child is having any renal impairment. And then for MBLs, you should always have your aztreonam and ceftazidime avibactam as in combination to form a decoy for all the resistance that is fighting, which is coming against it. And this is all I wanted to tell. Thank you.
Thanks, Kavin, for that. Just a couple of comments. So, in the type of resistance that you don't see in India is KPC. It's not OXA. For us in India, for E. coli and Klebsiella, OXA48 and NDM are almost equal, or some, maybe NDM is like more than OXA. So, for Klebsiella, again, OXA is a very important resistance mechanism. So, that was one thing I wanted to correct, and otherwise, it was sort of very well done. And the other thing is about Aztreonam avibactam. You mentioned that it's a good agent if it's available. So in India, it's available. Unfortunately, this drug doesn't have a pediatric dosing as of now. The company itself has not come out with a pediatric dosing. So pediatric trials are ongoing, and then probably once we have it, we'll start using it. But adult patients have started getting Aztreonam avibactam in India. So that is something that we should remember. And again, there is no head-on-head large-scale RCT comparing polymyxin versus ceftazidime avibactam and other things. But whatever available observational data and small RCTs that we have seems to suggest, and also from clinical experience, all of us feel that the newer beta-lactamase inhibitor like ceftazidime avibactam are much safer as well as efficacious in clearing infections with carbapenem resistance. But having said that, the word of caution here is, you mentioned about IMPRESS trial and all that. So let's not assume that every patient who comes into our ICU has only resistant bugs if they are not improving. We always teach you in pediatrics about, say, how to react to a non-responding infection. It doesn't mean just pumping antibiotics. From peptides, you go to meropenem. From meropenem, you go to tigecycline or ceftazidime avibactam. So that is what is happening in most ICUs, but that shouldn't happen. So that is a separate talk in itself. But keep that in mind. Let this talk not skew you towards thinking more and more about carbapenem resistant bugs and treating all your patients with these drugs. So, sir, anything you wanted to add?
No, the only thing is, where do you really use only Aztreonam with avibactam without ceftriaxone?
Without ceftazidime.
Without
Actually,
ceftazidime.
yes, in
No,
that combination paper,
definite indication for use of
yes,
the
NDM
standalone
only, sir.
combination.
Yes, Aztreonam avibactam is used for NDM. It is the ceftazidime avibactam is used for OXA48. The reason being, in the ceftazidime avibactam aztreonam component, as he explained very well, the ceftazidime is useless. We are using aztreonam to overcome the NDM enzyme, and because NDM doesn't exist alone, it exists with ESBL or AMC. So you need aztreonam doesn't work on ESBL or AMC. For that reason, you are adding avibactam so that avibactam will take care of your ESBL mechanisms and other things. So that's why when you use aztreonam, it acts on NDM. When you use avibactam, it acts on the ESBL. So if you put it both together, it will act on the NDM bugs. You don't need the ceftazidime component for treating an NDM CR, E. coli or a Klebsiella.
Of course, one strong message for this, I think, is that colistin is on the way out.
Yes.
Yeah. Now we have alternatives, safer alternatives than colistin. Wherever they have used colistin, the mortality rates have been very, very high, and colistin is out. And second is that people should not get carried away by the new dirty drug, I would call it, the ferropenum, which is not a carbapenem, and even if the lab gives you or the companies tell you to write it for ESBL, please don't use the drug at all. In fact, I am fond of calling the drug as unferropenum rather than ferropenum. People are tempted. I have seen prescriptions for UTI, ferropenum, which is totally unscientific.
And just two points I wanted to say. So if there are any new people with interest in neonatology, so in newborns, you would see a lot of, in the larger centers, you would see of sometimes a carbon-resistant E. coli, meningitis, and sepsis and other things. So fosfomycin is a very good drug, which has very good action against E. coli. It's not at all a drug to be used for Klebsiella, as I think Kavita mentioned. It has an enzyme called as FOSA and other things which prevent it from, the data seems to suggest that you shouldn't be doing it. That's what is the usual clinical agreement. So E. coli, on the other hand, there are instances where ceftazidime avibactam plus or minus aztreonam might fail, but fosfomycin is almost always universally susceptible. So, and it has a good CNS penetration. So for people who are working in NICUs, that's a very good drug to use. And again, about your TG cycline, I think one Dr. Harsha had asked. So definitely, as Kevin pointed out, never to be used when you have a primary bacteremia, like you have a line-associated infection and bacteremia, don't use. But you have a source, like say a bad SSTI or a bad pneumonia, then maybe you can use TG cycline because it has excellent tissue levels. Okay, so in this talk, actually, as Sir rightly said, for your CRE, colistin and polymyxin are on their way out. We are not at all using them in practice because we have better drugs like your beta-lactamase inhibitors. But you will be surprised when we move on to our next talk. Our next talk is going to be the last talk on carbapenem-resistant Acinetobacter. It's one of the greatest challenges in Indian ICUs, in most of the Indian NICUs and adult ICUs. For some reason, pediatric ICUs don't, many centers don't have this. It's a good thing because this is one of the toughest bugs. The carbapenem-resistant Acinetobacter is one of the toughest bugs, and we have very few drugs available in India to treat this. So that's why I chose my ID fellow, Dr. Manogna. Manogna, you can start sharing your screen. So she is going to take us through the treatment and what are the current medications that we have that are available for carbapenem-resistant Acinetobacter, and what lies in the future, like what are the drugs that can likely to come up in the future, what is likely to happen in the Indian scenario. Manogna, are you there?
Yes, ma'am.
You can start sharing.
Ma'am.
Or you want me to share?
Yes, ma'am. Please do share, ma'am.
I don't know. I'll just see if I got yours. 1 minute.
Sure, ma'am.
Sorry, give me a minute. Yeah. Yeah. Sorry about that. Yeah, you can get started, Manogna.
Good evening, everyone. I'm Manogna from Apollo Hospitals, Chennai. I'm an ID fellow working in Apollo Hospitals. So today I'm going to talk about carbapenem-resistant Acinetobacter baumannii. So what are we referring to? The crab, what are we referring to it? So it's a gram-negative non-fermenting Aerococobacillus. It's classified as an urgent antibiotic-resistant threat by CDC in 2019 and a critical priority antipathogen by WHO in 2024. It's predominantly a nosocomial pathogen rather than an environmental one. So, in environment, it's an hardy organism with propensity to spread within hospitals and has predilection to infect critically ill patients. It's primarily found in hospital environments, particularly in neonatal and adult ICUs, cancer units, neurosurgical and burn units. So, most of the isolates are from respiratory tract or bloodstream or central nervous system. Next slide, ma'am. So this slide, it shows the group of syndromes caused by CR Acinetobacter. First being the most important ventilator-associated and hospital-associated pneumonias, and bloodstream infections, catheter-associated UTIs, surgical site or skin soft tissue infections, meningitis, bone and joint infections. So, crab acquisition, this slide shows the risk factors, which can be divided into a hospital risk factors as well as patient associated risk factors. In hospital risk factors, most important one being the hospital density crab unit, high density crab unit. So, and along with the contaminated surfaces like gowns, gloves, BP cuffs, furniture, hand sanitizer containers. So here, infection control plays an important acts as an important check for crab acquisition. And in coming to patient risk factors, obviously very sick patients who are on ventilators, who are in ICUs, who have broad spectrum antibiotic exposures, with comorbidities like diabetes, polytrauma patients on getting multiple blood transfusions, undergoing procedures like bronchoscopy. These are prone to crab acquisition. And coming to the resistance patterns in Acinetobacter baumannii. So this slide, it shows the global emergence of the carbapenem resistance in Acinetobacter baumannii over time, starting from 1986 to till date. So acquisition of multiple oxacillinases like 23, 24, 51, 143, 235. Most important being OXA23 in crab bacteria. So the first outbreak of OXA23 crab was noted in Brazil in 2003, followed by spread worldwide. And the coexistence of OXA23 and NDM1, which was the first case report in India and China, was noted in 2010, followed by worldwide spread. Next slide. So this slide shows the multiple resistant mechanisms in Acinetobacter baumannii. Most important being the beta lactamases A, B, C, and D. The most important beta lactamases in crab bacteria are MBLs or oxacillinases, that is class D. And other resistant mechanisms include altered porine channels and altered efflux pumps, which also act as resistance mechanisms. So coming to the common resistant mechanisms, so B and D, that is B is the MBLs, which we have already talked about in the previous by the previous speakers. Most important being the NDM in India, and followed by OXA23. So this graph, this pie chart is from IJCCM, where 58 bacteremias of crab were studied. So most of the 32% or 36%, whatever is showed in the graph as red and yellow, are co-producers, that is OXA23 plus 51 plus NDM, or OXA23 plus 51, and NDM alone being 4%. So most of the crab bacteremias are co-producers. So coming to the epidemiology, this slide shows the map, global prevalence of crab bacteremias, particularly the meropenem resistant Acinetobacter species. Most common being the red areas, which show high resistance rates of around 60 to 100%. So more in Latin America, North America, major parts of the Asia, and some parts of the Europe. So this slide shows the graphical representation from ICMR data studied from 2017 to 2024, where the purple line shows the meropenem resistant, that is the carbapenem resistance Acinetobacter susceptibility pattern. So the meropenem resistance in 2017 was around 20%, susceptibility being 20%. In 2024, it is less than 10%. And this is from the same ICMR data where Acinetobacter species were studied. Carbapenem total isolates were around 459. Carbapenem sensitive isolates were only 28, 174 being carbapenem resistance, almost nil ESBLs in this. And majority of the isolates were co-producers, like we have already previously seen, and 76 isolates were OXA23 producers. So how do we approach to a positive crab culture? Do we treat it, or do we just observe closely? So it depends on what from where the crab has been isolated. Is it a non-sterile site like airway, lung, or skin? Or is it a sterile site like blood, CSF, pleural fluid, or urine? So we don't treat all crab positive crab cultures. We look for signs of infection, despite from wherever it's isolated. If there is fever, elevated WBC count, or inflammatory markers, abnormal imaging, we definitely treat it. And if it is isolated from a non-sterile site, and if there is no active infection, like from some TT culture, tracheal aspirate culture, or ET culture, we just observe closely if inflammatory markers are elevated or not. If it's a sterile site like blood, CSF, etc., we look for presence of any indwelling devices like chest tube or EVDs, and we definitely have to remove the EVD. And if there are signs of infection, we need to treat it. So coming to the guidelines, first guideline being I want to discuss is the ICMR guideline. So ICMR, it primarily focuses on the combination therapy, at least use of 2 active agents in moderate to severe crab infections. Single agent can be used for mild disease. So this ICMR guideline primarily focuses on sulbactam backbone as the preferred strategy in crab infection. So either the high dose sulbactam or use of ampicillbactam, cefoperazone sulbactam is also okay. With sulbactam, a minimal dose of 9 grams per 9 grams per day to be used. So the sulbactam, it works well when it's sensitive or intermediate, but it does not work when it's resistant with an MIC of greater than 128. So we avoid in that state. And in India, as Indian prevalence is very high, the guideline recommends addition of polymyxin to sulbactam for bacteremias. We can add minocycline and TG-cycline for secondary bacteremias, but we have to keep the MICs in mind. So the minocycline and TG-cycline work well if MIC is less than 1. So preferably we have to use very high dose of TG and minocyclines in these cases. And ICMR recommends against use of nebulized antibiotics. Coming to a next guideline is the IDSA guideline. So IDSA guideline primarily focuses on sulbactam durlobactam combination with addition of other agents. So general approach is use of sulbactam and durlobactam along with a carbapenem, and preferred therapy being sulbactam based therapy like the ICMR being the backbone. And we can use other ampicillin sulbactam if the sulbactam durlobactam is not available. And other agents can be added to this like minocycline, TG-cycline, cefodericol, and it should be continued until at least the patient is hemodynamically stable. And prolonged therapies in cases like chronic osteomyelitis, we can step down to single agent. So polymyxin B, TG, cefidericol, these are not good as monotherapy agents. We have to definitely add it to sulbactam durlobactam combination or high sulbactam combination. And there is no role of rifamycin in crab therapies, and neither there is a role of nebulized or inhaled antibiotics in crab. Coming to the SMID 2022 guidelines, if crab is susceptible to sulbactam or if there is HAP or VAP, we use ampicillin sulbactam, but there is low certainty of evidence in this. And if crab is resistant to sulbactam, a polymyxin or high-dose TG-cycline can be used, but not much data is there on this. And this guideline, it recommends against use of cefidericol for treatment of crab infections. This also has low certainty of evidence. And for combination therapy, generally polymyxin meropenem combination is this estimate guidelines recommends against this combination, or polymyxin rifampin combination therapy is also is to be avoided according to this recommendations. And in case of severe and high risk crab, combination therapy is preferred. So role of newer drugs in Indian crab infection, sulbactam durlobactam, this is the novel beta-lactamase inhibitor, which should be used. And this sulbactam, it acts at 2 sites, that is PBP1 and 3, and it generally has an intrinsic activity against Acinetobacter. It also acts against ESBL. And durlobactam, it acts against other enzymes like AMC, OXA, but it does not have any action on NDM. So sulbactam durlobactam plus imipenem has synergistic effect because imipenem, it targets PBP1A and 2, while sulbactam, it targets 1 and 3. So there is synergistic killing effect. So we generally there is an indication of use of sulbactam durlobactam plus imipenem with addition of polymyxin for NDM producers. Next slide. Coming to newer drugs like cefidericol, cefepime, zidibactam. Cefidericol, it's a siderophore cephalosporin which binds to extracellular free iron, so which uses the bacterial active ion transport channels to penetrate the periplasmic space of GNB. So there are observational studies which show increased mortality in crab VAP with cefidericol, but the cohort data disapproves this. And it works on both OXA and NDM, but in India, 40% resistance rates are noted. And coming to cefepime zidibactam, this is also a novel beta-lactamase drug. It works against all resistant types and also on Acinetobacter baumannii, and unlike ceftazidimavibactam, it works on OXA, but there is no activity against NDM. So sulbactam add-on is generally recommended. So coming to the treatment summary, so the main drug is the high-dose sulbactam with addition of polymyxin B to act against the NDMs, which is common in India, with addition of mino and TG cycline in high doses, keeping the MICs in mind. Particularly in secondary bacteremias. In UTI, we substitute the polymyxin with colistin because there is no renal penetration of polymyxin, and we do not use mino and TG cycline in UTIs due to low renal penetration. We generally avoid combinations like polymyxin with meropenem or polymyxin with rifampicin, and we avoid trimethoprim sulfamethoxazole in moderate to severe infections. So the take-home points I want to tell are, if there is positive crab culture, most of these isolates are generally colonizers. So we have to look for clinical signs, and are we isolating it from sterile sites to treat? And crab infection in India, treat with therapy with sulbactam backbone, add polymyxin due to high NDM prevalence, and add TG and mino if there is secondary bacteremia. Thank you.
Okay. Thank you, Manogna. So this actually is the peak of resistance that you can see in India, carbapenem-resistant Acinetobacter. As you can see, even the newer drugs like sulbactam, darlobactam are not going to work because of the NDM phenomenon in Indian crabs. And cefiderocol, already the resistance is there, and then we expect only 40 to 50% susceptibility. Cefepime ziribactam, again, not yet into the market, but even if it comes, you are supposed to use it as combination. So it's a very challenging scenario for carbapenem-resistant Acinetobacter in India. But again, as I said earlier, Indian NICUs have a great problem with carbapenem-resistant Acinetobacter. But the only way forward for carbapenem-resistant Acinetobacter is infection control, and infection control, because you're not going to be getting good drugs. So if you have a patient with carbapenem-resistant Acinetobacter, in addition to treating the patient, make sure that your hospital environment doesn't get colonized and your healthcare workers do not cross-transmit the infection from that patient to the other patient. They are not actually very virulent bugs, but they can kill because of their resistance itself. So I think with that, I think we're very well past time. So maybe Lakshmi is getting a bit jittery. So I would ask SBS sir for his comments and then any questions that we have.
I know very little about crab. The only thing I can mention from what I have read in literature, you are allowed to use chloramphenicol if your lab gives you sensitivity. That's one thing I have read. I'm sure Vidya would agree. I have seen papers also mentioning, sympathetic use of, allowed use, permitted use of chloramphenicol for crab if your lab gives you sensitivity. That's an interesting thing. But otherwise, I don't know much about crab. But that's very interesting to use, sulbactam. Otherwise, we don't use pediatricians. We don't use ampicillin sulbactam at all. So that's very interesting. I know very little about it. Thank you.
Any questions or?
The questions were in the chat box and it has been already taken up by you and sir. So I think it was a pleasure listening to you, Dr. Vidya, and of course the way you've mentored the students. We're also fortunate to have our legendary teacher, SBS sir. Of course, without him, this wouldn't have been possible at all. So Nachine Nale Superbugs we have discussed, and just to sum up what I thought, I mean, I'm no expert here, but first, the MRSA, of course, it's the global pediatric colonizer reservoir. I thought it's important for us to understand that treatment failure looks different in kids. So treatment failure is more driven by musculoskeletal, vascular, or ICU infections than by low vancomycin levels, which is the traditional teaching in adults. And then for the ESBL, of course, we know neonates, they are the frontline casualties, hardest hit. And it's also important for us to remember that cephalosporin sensitivity in vitro can be misleading because we can see clinical failure despite a susceptible report. And CRE, I think they just represent the end of the antibiotic line. And I'm a nobody to talk about crab because I'm not in a level 3, level 4 unit, but I do understand that it's a very stubborn environmental Trojan, a lurking survivor. I think it can survive for several weeks, even on dry surfaces. And it's a carbapenem busting clone, and the therapeutic options are very dismal. So I think this is what I took from the presentation. It was wonderful, no jitteriness at all, just jittery, thinking about the future. But we are all wise at the end of the day. And I would very much like to thank everybody who made this possible, starting from SBS sir, Dr. Vidya Krishna, the 4 presenters. Can we have the 4 presenters? Can you turn on your videos so we can see the wonderful, enthusiastic students who have presented today? Very tough topic, beautifully presented. Can we see you all, doctors? If you can turn on your video.
Except Manogna, I have not seen anybody, please. Yeah, hi. It'll be good to see.
Yes,
Kavita,
wonderful
Kavin.
presentations by all.
Yeah.
We also would like to thank the head of the departments of the respective institutions, the PG coordinators, who have so beautifully allotted the topics to these students. So I think my heart goes out to the PG coordinators and the HODs, Dr. Sneha from CMC, Dr. Divya Lakshmi from Ramchandra, of course, Dr. Vidya from Apollo, Dr. Aparna from Rainbow. Thank you so much. Thanks to the enthusiastic audience as well.
I would like to pay a special appreciation to all the 4 PGs. You are more like a teachers for us today. Everything is really making us to go back and read. It's an alarming thing that we are missing a lot. SPS are very happy for selecting this topic actually. And it's a it's a great blessing. You are here to guide us actually. Lakshmi, can you come out of the live streaming? Stop the live streaming. We can have a small discussion.
Yes, I'll just stop the live streaming.
I just wanted to make a comment.